So continuing on looking at type 1 diabetes, we look at the medications. So when looking at someone who has insulin-dependent diabetes, obviously the primary concern here is the exogenous insulin. So insulin is going to be injected intramuscularly or in the lower abdomen. We'll kind of talk about some of the particularly as far as when you're looking at exercise, how the what's kind of the better option there. Or via an insulin pump. Some individuals wear an insulin pump, which is just a constant flowing insulin that's kind of attached to them. But the only thing is you do not have insulin in pill form. There is actually also a newer inhaled form of insulin that is also getting used as well. But there's different types of insulin. So there's the rapid acting insulin, which will reduce blood glucose in 15 minutes, but only lasts for several hours. There's what you have short, or what they can typically consider a regular acting insulin, which reduces blood glucose in about 30 minutes and continues for 3 to 6 hours. You have your intermediate acting insulin, which doesn't reduce blood glucose for a little while, but is effective for up to 18. And then you have longer lasting insulins, which will pretty much look to kind of keep levels steady for about 24 hours. So essentially, when you're looking at this, it's going to be based upon the way insulin is going to get, the type of insulin is going to be used, is going to get prescribed, is going to be based upon the degree and rate at which the individual needs to affect their blood glucose levels. So that's what they're going to be looking at. The inhaled insulin that I kind of talked a little bit about is basically delivered in like a fine powder with an air-propelled inhaler or nebulizer to the individual's lungs, where it kind of crosses into the bloodstream a little bit faster. So that's kind of a newer type. I'm actually not even as familiar with that because it's a relatively newer type of insulin administration. And for the most part, most individuals are still using the injectable. Again, the insulin pump just kind of continuously administers rapid or short-acting versions of the insulin through a little catheter that's actually placed under the skin. So sometimes individuals with insulin pumps will need varying degrees of insulin. And again, you're obviously not going to have to know what type of insulin the person should be taking. You should just be aware of what type they're taking, because obviously that could kind of fit into the education as far as like how they're eating and everything, and when they're taking their insulin relative to exercise. So it's good to know what type they are taking and kind of how that affects. So you should know how all these types of insulin based upon their timing kind of affects the immediate blood glucose, and then for how long it impacts it later on. So looking at the effects of exercise, so we had discussed this previously, but we'll kind of go through some of the things that are listed. So we have the reduced HbA1c levels. Again, that's indicative of your average blood glucose level. You have improved body composition, lower blood pressure, lower blood lipid levels, and just decreased overall mortality. The one thing particular with type 1 diabetics, because they'll be taking insulin, you do have to be aware of hypoglycemia and episodes of hypoglycemia. So, and that can be caused during or after exercise, or during sleep after exercise. So part of what we're going to be talking about with the recommendations is kind of how to monitor their blood glucose and kind of how to proceed as far as exercise intensity, whether or not they should be consuming a carbohydrate or not before or during activity. And that's going to be an important thing to know as far as like, just from a test question standpoint and everything else, just kind of understanding how to kind of manage somebody with type 1 diabetes. It should be known that overall moderate intensity exercise is kind of the best overall at controlling blood glucose. But, obviously we want to, if possible, if high intensity training, because there are particular benefits to that as well, should be used, and when it's appropriate to be used. So kind of monitoring the blood glucose with that. So the exercise recommendations, again, if you look at table 4.6, they're similar to type 2, what you look at with someone who is a type 2 diabetic. What we're going to be talking about and looking at here is looking at how we should kind of manage the exercise intensity based upon blood sugar levels. So if your pre-exercise blood glucose levels are under 100 milligrams per deciliter, you should consume an individual should consume about 15 to 30 grams of carbohydrate unless the exercise duration will be less than 30 minutes or at a very high intensity, okay? If the session's going to be longer than 30 minutes, you want to make sure you're getting the 15 to 30 grams of carbohydrates. If your pre-exercise glucose levels are between 90 and 150, that commonly necessitates carbohydrate to be ingested at the beginning as well and throughout the session, usually at the rate of about 0.5 to 1 gram of carbohydrate per kilogram of body weight per hour. Okay, so that's what you want to essentially be looking at as far as the blood glucose levels. If you're talking higher levels of blood glucose, so if pre-exercise blood glucose levels are between 250 and 350, now is where you look to do a ketone test. So if you have blood glucose levels at that point with moderate to large amount of ketones, they should not exercise. If the ketones are lower, so light to moderate levels, then low to moderate intensity exercise is okay, but wait until the levels are under 250 for blood glucose before doing high intensity exercise. Okay, so again, if the ketones are low, so if you're looking at a blood sugar between 250 and 350, if ketones are low, light to moderate intensity exercise is fine. They should not do high intensity exercise until their levels are below 250. If your pre-exercise blood glucose levels are over 350, measure ketones and again delay again if they're moderate to high. If the ketones are negative or trace, administer insulin based upon the healthcare professional's recommendations. And if ketones are in an acceptable range, mild to moderate intensity can begin, but intensity should not go high until blood glucose levels are under 250. Okay, so again, you might want to take a minute and just kind of review those guidelines, make sure you have all that straight in your notes. But that's essentially what you're looking at in as far as, is their blood sugar high? Is their blood sugar low? If it's low, when how much do they have to consume in carbohydrates? If it's high, check ketones. If the ketones are at an appropriate level, low to moderate intensity exercise. Okay, so those are some different points to keep in mind as we look at how. And again, your other recommendations will be very similar to what you see with type 2 diabetics. So dyslipidemia, so is abnormal blood lipoprotein concentrations, and again, this puts an individual at risk for various cardiovascular pathologies, as you see listed here, atherosclerosis, heart attack, and stroke. This is going to be characterized by elevated total cholesterol, low-density lipoproteins, triglycerides, and low levels of high-density lipoproteins. So we'll talk briefly about the difference between high-density lipoproteins and low-density lipoproteins and what that means as far as the overall health and the numbers. Because when we're looking at these numbers, there's obviously some things we want to be taking a look at here as far as how to manage the individual here. So again, components of blood lipids. So the total cholesterol number represents all forms of cholesterol. Now, this doesn't tell you the entire story as far as the individual's predisposition to some of these cardiovascular issues that we discussed. So we have to look at the different parts. LDLs with VLDLs are the very low density lipoproteins. They're the major carriers of cholesterol in the blood, and they deposit cholesterol in the lining of the blood vessels. So this is the direct thing that contributes to atherosclerosis, okay? So when you're looking at that total number, you have your total number, and then you have these other components, the LDLs and the VLDLs. They're the ones that are responsible for depositing the cholesterol within the blood vessels. Chylomicrons are small fat and protein molecules that transport the fats from the intestine to the liver. So again, these are also high levels of these will also contribute to atherosclerosis. Your HDLs can remove cholesterol from the blood and transport it to the liver. So high density lipoproteins or HDLs, they're actually, this is what's known as, people call it the good cholesterol, because this is the form of cholesterol that actually moves the cholesterol, transports it to the liver to be processed. So you actually want this number to be elevated, because this actually helps to remove cholesterol. So low levels of HDLs, particularly in conjunction with high LDLs, is what really puts an individual at risk for cardiovascular issues. So here we see our different levels. So this is what we look at as far as optimal, normal, borderline high, high, and very high. So if you're looking here, you can see these various numbers. So take a minute to look at this. Triglycerides, I didn't talk about them on the previous slide. So triglycerides are essentially lipids that are carried in the bloodstream to the tissues. So most of the body's fat stores are actually in the form of triglycerides. They are found in the muscle and used for energy. Triglycerides are another thing where, again, high levels are associated with high risk for atherosclerosis. So again, we're looking at those numbers to be lower as well. Again, it's a combination of all of these factors, so you don't necessarily just look at total cholesterol and have that be kind of the end determinant for how the person is managed. We want to look at the ratio, the LDLs, HDLs, and we want to also look at what the triglycerides are as well. So medications, there's various medications that can be utilized, and again, you could see them in the medications table. Probably the most common one that everybody knows about are your statin drugs. Okay, so your statin drugs essentially are going to be used to help in lowering the overall cholesterol levels. Some other drugs that also get used, niacin is one commonly prescribed. You can actually get niacin over the counter as well. Fibrates, fibric acid, bile acid binding resins, cholesterol absorption blockers, and omega-3 fish oils. And again, omega-3 fish oils are actually over-the-counter supplements that you can get as well, but there's also prescription omega-3 fish oils. So again, take a look at them. Again, note some of the more common side effects. Statin drugs are very commonly prescribed medication for this, but they do have side effects that could particularly affect exercise as well. So again, exercise and lifestyle management can be important here. So again, we want nutritional adjustments to help improve the blood lipid profile. Again, some general educational recommendations you can make. Again, a dietitian is someone who would give overall diet plans in this instance, but some general recommendations you can make. Again, increasing fiber intake. The individual in all likelihood is going to have to reduce their overall calorie intake. Um, Reducing fats, but be careful with reducing fats. I mean, obviously you do need fats in the diet, but you will probably reduce the overall fat intake. And again, combining the dietary changes and doing both aerobic resistance training, you can decrease your triglycerides and also help to increase your HDL. So exercise has actually been shown to increase HDL, which again is um, the good cholesterol that helps to remove it from the bloodstream. Again, your exercise recommendations are posted. Again, aerobic training involving rhythmic movements, with large muscle groups, walking, jogging, biking is all going to be good, stair stepping. 4 to 7 days a week in smaller bouts or longer bouts up to about 60 minutes a day. Resistance training starting with 2 or 3 days per week. 50 to 85% of your 1 rep max. Again, flexibility training. So again, overall training with this, again, review those specifics and kind of make notes in the outlines that I've given you. The thing to note, I did kind of bring up statin drugs earlier on when talking about medications. So individuals on statin drugs might experience some enhanced muscle damage or pain. So it could affect their strength or endurance. So if they are on statin drugs, make sure to kind of, and they're just starting exercise, make sure to watch the intensity. And then if they start to have problems, refer them to their physician as needed. So looking at hypo and hyperthyroidism, we're going to look at hypothyroidism first. So hypothyroidism is underproduction of thyroxine, which is a hormone produced by the thyroid gland. So your symptoms are going to include fatigue, cold tolerance, muscle aches, painful joints, loss of bone minerals, lower cardiac output, and bradycardia. So basically, like the person's, again, we know the thyroid kind of overall kind of helps with our metabolism. And when you have underproduction of thyroxine, you're going to end up basically having these symptoms associated where the body, is very tired. Again, they're intolerant to cold and have these other symptoms that I brought up. This could potentially lead to a goiter or an enlarged thyroid gland or a potentially fatal myxedema, which is basically swelling of tissues in the skin. Again, this can be caused by various things. It can be caused by an iodine deficiency, autoimmune disease, or removal of the thyroid gland if someone has had to have their thyroid gland removed. Hyperthyroidism is an overproduction of triiodothyronine or thyroxine. So now you're getting basically an overactive thyroid, and the most common cause or most common presentation of this is through what's called Graves' disease. And again, basically, the thyroid hormones regulate metabolic rate, and overproduction causes nervousness, tachycardia, increased cardiac output, heat intolerance, and muscle weakness. Okay, so through different mechanisms, so this is an important point to make, through different mechanisms, both hypo and hyperthyroidism cause increased exercise intolerance. So in other words, both of these will cause issues as it relates to exercise. It's just for different reasons. Okay, so for instance, hypothyroidism, if you think about it from this perspective, exercise will be difficult for someone with hypothyroidism because they can't kind of bring their body up to do what it needs to do for exercise. So if you think about it, when you exercise, your heart rate has to go up, basically your metabolic processes have to increase. Hypothyroidism, the body has trouble doing that. With hyperthyroidism, it's almost like it ends up being too much. So since they're already at rest, having these, for instance, increased heart rate, increased cardiac output, it's almost like too much for the body. So in both instances, you're having intolerance to exercise. It's just for different reasons, okay? Typically you're going to see with individuals, they tend to have slow recovery from exercise in both instances, and also lowered anaerobic threshold and elevated respiratory stress. So basically in either situation, the individual is going to have difficulty with exercise. So obviously when you're planning the exercise for these individuals, whether it's hypo or hyperthyroidism, there's going to be things that have to be kind of modified in each instance. So again, your medications, so hyperthyroidism usually involves thyroid replacement therapy in the form of synthetic thyroxine. So again, you have an underproduction there, so that's where you'd look to do it. Again, there could be a number of side effects on heart function, nervous system, muscular system, and metabolic control. So again, issues with the thyroid gland and these hormones are going to cause problems elsewhere. We know that, anytime you have an issue, whether it be, hormone issue, hormone producing organ, there's going to be systemic effects throughout the body. So that's going to be an important thing to see. Elevated blood pressures and heart rates should be expected and accounted for when somebody is taking these medications. With hyperthyroidism, again, here we're gonna the treatment's primary goal is to prevent thyrotoxosis and contaminant heart rhythm disturbances. So we're making sure to make sure that, again, because now in this case you're looking at overproduction, we have to make sure that the individual that the medications are going to kind of control and prevent the individual from having too much thyroid hormone and the issues associated with this. So antithyroid drugs are given and they adjust the dosages until euthyroidism or normal thyroid levels are reached. Beta blockers may also be prescribed. So basically, what a beta blocker will do is slow the heart rate, and this will help prevent the effects of thyrotoxicosis. But the exercise heart rate cannot be used to monitor intensity then. So because the heart rate is going to be kind of getting manipulated with this, you need to find some other way to kind of monitor the exercise activity for the individual. So before I get into the effects of exercise on hypo and hyperthyroidism, a couple points to get. Again, the primary goal for a patient, whether they have hypo or hyperthyroidism, is again to establish that euthyroid state and to carefully monitor them for symptoms. So again, once euthyroid is established, guidelines for healthy individuals can typically be followed, but until that point, there are some things that you do have to kind of watch out for. So particularly, and I want you to highlight this. I'm going to go through some of the information, but in table 4.9 in your text, you have the negative effects of hypothyroidism and hyperthyroidism on exercise capacity. So before we get into the positive effects from them exercising, you have to understand what the condition does regarding exercise. In other words, someone with hypo or hyperthyroidism, what happens to them when they exercise? And some of this we did already kind of talk about, but there's a couple things you have to look at. Is one, you have to look at the whole idea of exercise intolerance. So in other words, how they have trouble tolerating exercise. And again, that's going to be due, again, hypo versus hyper. And hypothyroidism, again, they're not going to get the blood flow to the skeletal muscle that somebody would normally get. And then therefore, the benefits of getting increased blood flow to the skeletal muscle is not going to take place. When you look at hyperthyroidism, they're going to have an increased heart rate even at submaximal intensity. So again, you have to be thinking if they're having too much thyroid hormone produced, that's going to cause an increase in heart rate. They're going to have an increased reliance on muscle glycogen, and then they're going to have a reduced heart rate reserve. Again, obviously that takes you into the heart rate response. Again, hypothyroidism, their heart rate response is going to be depressed. Hyperthyroidism, they're going to have always an elevated heart rate relative to their exercise intensity. So go through, there's a couple other examples. So in other words, they talk about systolic blood pressure. They talk about heart rate recovery, which we know is important. They talk about anaerobic threshold. So look at those variables and either make note of them or just kind of mark that off in your text as you're kind of going through some of the material. As far as the beneficial effects, when we talk about the beneficial effects on somebody with hypothyroidism, so lower cholesterol increase, it'll actually help to increase their metabolic rate. Again, if you have hypothyroidism, your metabolic rate is going to be decreased. Improved mood and weight loss. So again, these individuals will tend to have more issues as far as like weight is concerned. Again, the cholesterol could also be an issue. So those would be things that would be improved in individuals with hypothyroidism. Hyperthyroidism, reduced joint muscle stiffness, improved density, and increased muscle tissue. So again, these individuals will have, again, the overactive metabolism, which would cause issues in some of these different areas, and again, be aware of the other things I described previously. Again, you could look at the exercise recommendations. Again, we've kind of discussed this a little bit in class as to how, particularly when you look at certain modes of exercise, again, there are going to be some slight differences here and there, but for the most part, again, low to moderate intensity always is kind of an ongoing theme. Eventually, you do want to work the person to maybe doing a little bit more difficult exercise as they start to progress, but again, you have to make sure you have an appropriate starting point for everybody. Now looking at chronic kidney disease. So chronic kidney disease is going to be classified based on the glomerular filtration rate, and it's staged from 1 through 5. Now what the glomerular filtration rate is the rate at which the nephrons, which is the kind of like the little operating units of the kidneys, if you will, filters the body's fluids. And the other thing, this looks at the extent of actual kidney damage. So when you're looking at this, so the stages, again, range from stage 1, where the glomerular filtration rate is normal, but there's some kidney damage, all the way to stage 5, where basically the kidneys are functioning at less than 75%. So all stage 5 individuals usually are going to require dialysis, and they're going to become candidates for essentially kidney transplants. And when we're just looking at individuals with chronic kidney disease, the majority of these individuals have, diabetes, hypertension, because that's going to be contributing to the damage to the kidneys. And again, here's just some other points that we kind of look at. So I mentioned the stage 5 kidney disease and what that means. And again, the kidneys get damaged due to inflammation, high blood pressure, high blood glucose levels. So again, as I mentioned, most of the individuals who have chronic kidney disease usually end up with, usually have another pathology associated with it. So some things we look at with individuals with chronic kidney disease. So muscle fatigue is a very common thing that individuals will be dealing with. And individuals with end-stage renal disease, their functional capacity is only 60 to 70% of normal. So individuals in this situation, their exercise testing is going to have to be done in a clinical environment. So that individual will begin a lot of their early kind of activity and fitness through a medically supervised program. The other thing we see is that as end-stage renal disease progresses, individuals are less likely to be physically active, and so their functional capacity does continue to decrease. So it's important to kind of note to make sure that individuals, try to keep them as active as possible and as healthy as possible, but a lot of their initial work will have to be done through a medically supervised program. So before we get into some of the other things in medications, just to make note. So again, just to further get into the pathophysiology a little bit, again, the kidneys are basically the filtration system for the body. So all the blood in the body circulates through the kidneys at some point, and again, all toxins, waste products, and materials for elimination are then basically processed through the urine. And again, they also function to return fluid and other parts of the blood back to the circulation process. So, and again, the basic kind of operating unit of the kidney is what's called the nephron. And again, part of that is what gets damaged as a result of chronic kidney disease. So again, that damage is going to occur due to like high blood glucose levels, again, from things like diabetes, stress on the vasculature in the kidneys from high blood pressure. If there's inflammation, okay, all of that will start to produce damage to the kidneys. So the end result of the disease is the process of renal dysfunction and in general end organ damage, where we talk about other organs then, such as the heart and liver also being affected. So and again, the pathophysiology of many of the chronic diseases, other chronic diseases, kind of predisposes individuals to this. So that's some of the basic information behind what is essentially going on here. So it's important that we all kind of have an awareness of these pathologies, as you'll be, if you're dealing with individuals in a regardless again, whether you're in one of the rehabilitation professions or an exercise professional, you have to kind of have an awareness of these pathologies. Okay, so looking at the medications, again, make sure to look at all your medication tables. So a lot of the medications that are going to be administered to individuals with chronic kidney disease are going to be administered to treat a lot of the comorbidities. So, a lot of the comorbidities like with heart disease, diabetes, hypertension, dyslipidemia. Um, some of the most common medications that individuals that will be dealing with are diuretics and erythropoietin stimulating agents. So again, review those and kind of see the side effects and everything. So again, make sure you have a working knowledge of the effects of those particular medications. So they're all listed. So again, kind of have an idea for the medications that are listed in general, what they do, be able to recognize them as medications for chronic kidney disease. As far as the effects of exercise, so again, the big thing here, and you see this with a lot of other things, is that just maintaining function and functional capacity could increase in a similar manner to those without end stage renal disease. So again, just the increased ability to carry out daily activities, increased muscle strength that you get from the resistance training, lower blood pressure, reduced inflammation, decreased cardiovascular risks. Again, those are some of the known effects that we know from both the combination of different types of fitness and modes of training, like resistance training and aerobic training. So your exercise recommendations, again, they're similar to those with the comorbidities like diabetes and hypertension, but again, they have to be modified based on the functional capacity. So depending upon what stage they're at and kind of what their capacity and ability was before that, that's again where some of the things may have to slightly be modified. Again, aerobic exercise should be carried out most days. Again, moderate intensity, 20 to 60 total minutes per day. And then again, your resistance training, 2 to 3 days a week. Again, you can start with one set of 10 to 15 repetitions per exercise at 70 to 75% of a one repetition max. So again, little different recommendations compared to maybe what you've seen percentage wise, but you're still kind of within that range. A lot of the different things that we've talked about in the past, they've all kind of looked at 60 to 80%. So this still kind of falls within there. Again, the bottom line is typically you're not doing above 80% for most of these individuals, because they're definitely not going to be able to start at that point. Again, a lot of people that have these issues, in all likelihood, haven't been as active in the past, or at least have been active recently. So this kind of gives you a starting point to kind of build up their capacity. And then again, you could kind of see down the road, depending upon how old the person is and how well they progress, how you kind of change that over the course of their training. And here are your learning objectives. Again, make sure to kind of go through these. Again, make sure you could kind of understand the pathology of these. Make sure to review the tables as I've talked about, and we'll work with this further in class.